Good afternoon, everyone. I hope everyone is doing well. We apologize. We have a last-minute cancellation of the first presentation, which will be rescheduled. Welcome you all to. I would like to welcome you all to the 26th week of our academic activity. We only have one lecture today, which is Atrial Septal Defect by Dr. Abdul Hadi Al-A'ma. Dr. Abdul Hadi, whenever you're ready.
Can I start?
Yes, Abdul Hadi, you can start.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. أنا عبد الهادي الأعمى and my topic is about atrial septal defects. These are the outlines I'm going to cover, inshallah. Definition and epidemiology, normal development of the atrial septum, classification of the atrial septal defects, natural history and clinical features, surgical techniques for repair, and we're going to talk about some of the technical pitfalls during ASD closures. Atrial septal defects are defined as an opening in the interatrial septum. It represents 10 to 15% of all congenital heart defects. The incidence of ASDs may be increasing due to increased use of echo screening in neonates. For the development, the septation of the atria begins as early as the 5th week of gestation and involves three main structures: the septum primum, the septum secundum, and the atrioventricular canal septum, which is made up in part by the superior and inferior endocardial cushions. The septum primum arises from the superior portion of the common atrium and grows towards the endocardial cushions. The fusion between the septum primum and the endocardial cushions closes the orifice known as ostium primum, separating the right and left atria. A second orifice develops in the septum primum. This orifice is later on covered by the septum secundum that arises on the right atrial side of the septum primum. The septum secundum grows caudally and covers the ostium secundum, forming the foramen ovale that is covered on the left side by the flexible flap of the septum primum. In 70% of individuals, the septum primum and septum secundum fuse during infancy or early childhood, creating an intact interatrial septum. However, excuse me. However, in some cases, the septi do not fuse. If the foramen ovale is completely covered but not sealed, this is called patent foramen ovale or a PFO. Based on their anatomy, ASDs are classified into primum ASD, a defect in the ostium primum, or secundum ASD, sinus venosus ASD, coronary sinus defects, and common atrium. Patent foramen ovale is not considered an ASD because no septal tissue is missing. Primum defects, also called partial atrioventricular septal defects, it develops if the septum primum does not fuse with the endocardial cushions, leaving a defect at the base of the interatrial septum that is usually large. This defect accounts for 15 to 20% of ASDs. Primum ASDs are usually not isolated, typically being associated with AV canal defects that includes anomaly of the AV valves and ventricular septal defects. Secundum defects, they are typically located within the fossa ovalis. They can result from arrested growth of the secundum septum or excessive absorption of the primum septum. The defects vary in size from less than 3 millimeters to greater than 20 millimeters. Secundum ASDs typically present as an isolated cardiac defect, though they may occur with other ASDs such as sinus venosus defects or primum defects. Some may have a functional mitral valve prolapse. These defects account for approximately 70% of all ASDs and occur twice as often in females than in males. Some may have a family history of this defect due to a specific genetic mutation. These are often associated with other congenital cardiac and extracardiac abnormalities, such as Holt-Oram syndrome, Noonan syndrome, or Treacher-Collins. Sinus venosus defects are characterized by malposition of the insertion of the superior or inferior vena cava, which then lies on both sides of the atrial septum. So they override the septum and communicate between the two atria. So the interatrial communication is within the mouth of the overriding vein and is outside the area of the fossa ovalis. This accounts of 5 to 10% of ASDs. Superior sinus venosus defects, or sometimes called superior vena caval defects, are located in the atrial septum immediately caudal to the orifice of the superior vena cava. The right upper lobe and middle lobe pulmonary veins are often connect the junction of the superior vena cava and right atrium, resulting in a partial anomalous pulmonary venous connection. Inferior sinus venosus defects, also known as inferior vena cava defects, are less common. They are located in the atrial septum immediately cranial to the orifice of the inferior vena cava. Inferior sinus venosus defects are often associated with partial anomalous connection of the right pulmonary veins. Coronary sinus defects, also termed unroofed coronary sinus. It's a part or the entire common wall between the coronary sinus and the left atrium is absent. This allows the blood to shunt from left atrium through the unroofed sinus into the right atrium, acting like an ASD. This rarer form accounts for less than 1% of all ASDs, and many patients also have a persistent left superior vena cava, which can be used as a clue for this anomaly. In some patients, the SVC drains directly into the left atrium and causes an obligatory right to left shunt and cyanosis. Common atrium happens when the entire septum fails to develop, resulting in a single common atrium. This is frequently found in patients with heterotaxy syndromes, and this may cause mild cyanosis. Patent foramen ovale, or PFO, is identified on autopsy in 30% of the adult population. The size of a PFO can range from 1 to 10 millimeter in maximal potential diameter. Interatrial shunting generally does not occur as long as left atrial pressure exceeds right atrial pressure and the flap valve remnant of the septum primum of the foramen ovale is competent. Mild shunting during the neonatal period is common, particularly in premature infants, and is usually considered a normal finding. During coughing or Valsalva, the increase in right-sided pressure may open the PFO. Natural history of ASDs. These, of course, the natural course of isolated ASDs, most of which are secundum ASDs. It varies. Small defects often close spontaneously in infancy, whereas moderate and large defects tend to persist and cause symptoms over time. Spontaneous closure is most likely to occur in patients with small secundum ASDs that are diagnosed during infancy or early childhood. Secundum defects of moderate and large size types of ASDs other than the secundum, and those are detected later in childhood or adolescence, are unlikely to close spontaneously, and some may increase over time. In patients with uncorrected moderate to large ASDs, left to right shunting may increase with age, leading to volume overload, heart failure, atrial arrhythmias, and pulmonary hypertension. Most patients become symptomatic before 40 years of age. The right-sided volume overload is usually well tolerated for years. Pulmonary vascular disease develops in 10% of older patients with isolated ASDs, but this complication is rare in childhood and adolescence. In the uncorrected older patients, severe irreversible pulmonary hypertension with right to left shunting develops, the Eisenmenger syndrome. And this may present with signs of right ventricular failure. Most ASDs are small and asymptomatic. They are detected by the presence of a murmur or as an incidental finding on an echo. Infants with large ASDs occasionally present with the symptoms of heart failure, recurrent respiratory infections, or failure to thrive. However, failure to thrive in infants with ASDs may be associated with extracardiac pathology. Paradoxical embolization and resultant embolic stroke is a rare complication of ASDs in pediatric patients. Physical examination findings are dependent on the size of the defect, the degree of shunting, and the pulmonary arterial pressure. Characteristics findings include a mid-systolic ejection murmur accompanied by a fixed splitting of the second heart sound. Signs of heart failure such as tachypnea, rales, failure to thrive, and hepatomegaly. Signs of right atrial enlargement. Right ventricular heaves, extracardiac features of associated syndromes may also be detected. On a chest X-ray, cardiomegaly may be noted and an enlarged right side, while the left side is normal. Increased pulmonary vascularity can be appreciated, and triangular appearance of the heart because the border is formed by the enlarged pulmonary arteries instead of the aorta. ECG may show a right axis deviation. Transthoracic echo is usually definitive in diagnosing the ASDs, but transesophageal echoes may be necessary for size measurements. Some ASDs may be detected prenatally, depending on the type of the defect and the experience of the operator. However, a postnatal confirmation is required. CT and MRI can be used to localize the pulmonary artery and to rule out partial anomalous pulmonary venous connections. When treating ESDs, they are usually addressed surgically or through interventional catheterization. No specific or definitive medical therapy is available, except for treating this heart failure or the arrhythmias. This decision to repair any kind of atrial septal defects is based on clinical echo information, including the size and location of the ASDs, the magnitudes and hemodynamic impact of the left to right shunt and the presence and degree of pulmonary arterial hypertension. In general, elective closure is advised for all ASDs with evidence of right ventricular overload or with a clinically significant shunt. If the QP or the pulmonary flow to systemic flow ratio, QP to QS, is more than 1.5, or clinically we can assess for right ventricular symptoms. Lack of symptoms is not a contraindication for repair. In childhood, spontaneous closure of secondum ASDs, as we mentioned, may occur. However, in adulthood, spontaneous closure is unlikely. Closure of an ASD, however, is not recommended in patients with the clinically significant shunting who already developed Eisenmenger syndrome. QP to QS ratio is 0.7 or less. And in those patients, they could their condition might worsen, and the prognosis will be worse if you close the ASD. For a transcatheter closure, it's now commonly used for many patients with ostium secundum defects. They require an adequate rim for anchoring the device. Patients with no adequate rim for anchoring are referred for surgery. You can see it very nicely in the picture. ASD repair surgically can be accomplished through a median sternotomy or a right thoracotomy. However, a sternotomy is preferred because it allows for correction of associated anomalies and discovered during the surgery, and because the thoracotomy carries a high risk of air embolus and right phrenic nerve injury. In most cases, the thymus can be divided in the midline, and resection of the thymus is not necessary. Pericardial patch is harvested at the beginning of the operation. An alternative is to use the polytetrafluorothioline patch. Of course, cardiopulmonary bypass is initiated with aortobicaval cannulation. For ostium secundum ASDs, the right atrium is opened using an oblique incision that is carried from the right atrial appendage in the direction of the IVC cannula. An attempt is made not to cross the crista terminalis to preserve all possible conduction fibers. The opening in the atrial septum is easily visualized through the opened right atrium. 5-0 polypropylene suture is used to anchor the patch to the edges of the ASD. Of course, the size is a surgical preference depending on the patients. With care, care must be taken to avoid suturing the Eustachian valve, because the suturing the Eustachian valve to the septum secundum would create an obligatory shunt of the inferior vena cava blood into the left atrium, and the patient would be cyanotic following the procedure. We're going to talk about this in the pitfall section. At the end of suturing and before tying the knot, valve alpha can be initiated by the anesthesia to de-air the left side. After tying the knot, another valve alpha will test the suture line for leaks. Then the right atrium incision can be closed and de-aired while patient rewarming is taking place, and the patient can be weaned off bypass and closed. Alternative techniques of closure of an ostium secundum include direct suturing of the edges of the defect, but nowadays the only ASDs that make it to the OR are usually not suitable for direct suturing. For ostium primum defects or partial atrioventricular septal defects, it usually can be repaired with a simple pericardial patch, similarly to ostium secundum defects, with or without mitral valve repair. For sinus venosus ASDs, the incision is carried from the tip of the right atrial appendage in the direction of the superior vena cava, right atrial junction. The incision stops short of the crista terminalis and the care is taken not to cross the cavoatrial junction. Sinus venosus defects always require closure with a patch because of their location at the junction between the superior vena cava and the right atrium. Direct suture closure can lead to right superior pulmonary vein or superior vena caval stenosis, or both. Between 20% and 45% of sinus venosus ASDs, they can be closed by a simple patch. If the ASD requires enlargement to allow an adequate channel to the left atrium for the anomalous pulmonary veins, an incision towards the fossa ovalis and resection of a portion of the limbus of the septum secundum is done. Very rarely, partial anomalous pulmonary veins return will occur to the superior vena cava. Right atrial junction without an ASD. In these patients, an opening must be created in the atrial septum so that the pulmonary veins can be diverted into the left atrium with the baffling technique. If the anomalous pulmonary veins enter the high superior vena cava, Warden procedure must be used. I'm going to show you a picture of the procedure. A high right angle SVC cannula is used with the division of the SVC immediately above the partial anomalous pulmonary venous connection to save the proximal SVC length. And then a patch is used to punch the cardiac stump of the superior vena cava to prevent stenosis. The right atrial appendage is opened with an incision in the tip. Sorry, excuse me. Okay. The SVC orifice in the right atrium is directed to the left atrium through the sinus venosus (ST) with a fresh autologous pericardial patch. Finally, the cut superior vena cava is anastomosed to the right atrial appendage using absorbable interrupted suture to prevent purse stringing and to allow growth. The azygous vein is preserved in case there is SVC stenosis. This is a picture of the Warden procedure. You can see mainly the work on this area, and this is the SVC cut separated from the partial anomalous veins and sutured to the right atrium. This is a patch to close the right atrium. So this is the new right atrium of the SVC and the IVC, and this is now the anomalous connection going through the defect into the left atrium. Technical pitfalls in ASD repairs. Difficulty in visualizing the lower edge of the ostium secundum defects, especially if the inferior vena cava cannula has been placed too high. This is particularly true for the patients who has no inferior rim and who has been declined for device closure. A large prominent Eustachian valve that can be mistaken for the lower edge of the ASD. And as I mentioned before, suturing the edge of the ASD to the Eustachian valve would cause an obligatory right to left shunt from the IVC to the left atrium, and the patient will become cyanotic post-op. Small fenestrations in the interatrial septum primum are a potential cause of residual shunting. These defects can be closed often primarily. That was my topic, and thank you.
Thank you very much, Dr. Abdul Hadi.
Thank you, Dr. Fuchs.
It's very nice lecture. Any question from the audience? So I guess your lecture is very clear, and no more question, no further question. We thank you again, Dr. Abdul Hadi, and we apologize again for yes. We apologize again for the first lecture, which will be rescheduled for a later date. I think this concludes. If no one has any comment, we'll conclude our activity for today. We thank everyone for joining.
Thank you, Dr. Abdul.